Hello everyone, I'm here to present an evidence review on how to reduce blood culture contamination. Why is this important? Studies exploring ways on how to reduce blood culture contamination is plentiful in current literature. Nonetheless, few articles focus on blood culture contamination from central devices. This work illustrates a review of evidence surrounding blood culture contamination from both central devices and peripheral sources. It is the hope of this work to guide decisions surrounding practice change in order to reduce blood culture contamination. Introduction. Blood culture testing is one of the most important and frequently performed diagnostic tools in emergency departments. Initiatives on reducing blood culture contamination have gained interest due to its impact. Majority of available articles pertains to blood culture collection from peripheral sources, but articles discussing central device interventions were limited. This review aims to search, appraise, and synthesize available evidence on blood culture collection techniques in reducing blood culture contamination and to make evidence-based practice change recommendations in reducing blood culture contamination on samples collected from both peripheral and central devices. Methods. This review followed steps 0 to 3 of the evidence-based practice framework developed by Melnick and Feinout-Overholt in 2019. An exhaustive search for evidence surrounding blood culture contamination reduction interventions from both peripheral sources and central devices was conducted using databases such as PubMed, Cochrane, and CINAHL. The search yield was screened based on titles, keywords, and abstracts targeting meaningful blood culture sample collection techniques and line management practices. Included articles were appraised for value and how it addressed the clinical inquiry. Interventions and outcomes were synthesized to present meaningful recommendations. The problem or the clinical inquiry. Inquiry to this focus stemmed from different perspectives. In the lens of patient safety, contaminated blood cultures predispose patients to unnecessary antibiotic therapy and length of stay more than expected. From the quality improvement standpoint, contaminated blood cultures could be considered as a waste, specifically a defect, in the patient care process rendering repeat testing. Institutions may have established their own process of measuring blood culture contamination. Lastly, from the vantage point of strategy, this issue impacts the organization economically, which results from unavoidable costs brought about by repeat testing and prolonged length of stay. Another source of curiosity came from a recommendation stated in the Infusion Therapy Standards of Practice in 2021, which states to divert and discard the initial blood sample when drawing from a direct venipuncture. The volume of blood that should be discarded or diverted to a different container is controversial, with 1.5 to 2 ml and 7 ml showing a reduction in false positive results. However, the discard or divert method aforementioned was not advised for central devices. When drawing blood culture samples from a central device, send the first sample drawn for culture without discarding. This raises a question as to why the discard or divert method could be used in peripheral sources but not in central devices. The evidence on interventions to reduce blood culture contamination from peripheral sources is ubiquitous, but scarce information could be gathered in the case of central devices. Thus, areas of opportunity to reduce blood culture contamination from central devices were identified. The PICO question. The PICO question for this work is, in patients whose blood culture samples were collected from central device or peripheral sources, how do best practice or strategies compared to current practice affect blood culture contamination? For the search strategy, databases, namely PubMed, Cochrane, and CINAHL, were searched using the terms listed below, which yielded to 177 articles. The software Covidence was used to streamline the screening process. From the 177 articles, 9 duplicate articles were removed. Not all articles which resulted from the search are specific to blood culture contamination. Interestingly, studies which focus on skin disinfection interventions, for example, chlorhexidine bathing, and different outcomes, such as central line associated bloodstream infection or CLABSI, were included in the results. 168 articles were screened based on their title, keywords, and abstracts. 150, 150 studies were removed using the exclusion criteria described here. 18 studies made it through the detailed review, and has made up the evidence synthesis. Evaluation, summary, and synthesis. Two articles from the screen provided valuable insights on how to possibly reduce blood culture contamination collected from central devices. 14 articles discussed interventions to reduce blood culture contamination from peripheral sources, and one article implemented different approaches to reduce contamination from both central and peripheral sources. Sufficient evidence is not available to endorse any recommendation to address central device blood culture contamination, while diversion technique was found to be effective in decreasing blood culture contamination from peripheral sources. This table shows the distribution of the level of evidence of the articles included in this review. Here's the synthesis of the interventions. For the central devices, both articles 1 and 2 on central devices resulted in reduced blood culture contamination. The investigations by Lewin in 2013 was performed through blood culture sampling during central device insertion, and it suggests that blood culture contamination was less from the sample collected from the non-wire hub. The non-wire hub is the hub and lumen from which the guide wire used during the insertion procedure was taken out, compared to wire hub. The second article found that blood culture contamination and incidence of CLABSI were less in the group which used passive disinfection. Passive disinfection was referred to as the use of antiseptic barrier caps. The third article initiated targeted interventions to reduce blood culture contamination from central devices, implementing policy that prohibits routine blood culture sample collection from these devices, and if needed, sample collection from these accesses were deemed necessary. Two nurse sample collection procedures and sample collection kit were necessary. The authors of the third article found notably reduced number of blood culture samples collected from central devices, decreased blood culture contamination, and reduced CLABSI incidence. Also, reinforcing the scrub the hub technique for central devices was implemented by the third article. In the included articles, blood culture samples from central devices were collected by nurses, except during insertion where samples were collected by physicians. As to the peripheral sources, the third article initiated also interventions that reduce blood culture contaminations from peripheral sources after reinforcing education on antiseptic technique for phlebotomists and venipuncture procedures for intravenous therapy teams. Snyder's review found that blood culture contamination was reduced with phlebotomy teams, but was not affected with the use of sample collection kits. Monitoring and feedback were found to be effective in reducing blood culture contamination by Burmese in 2021. Frequent education was also used by Sayed in 2020 study, which resulted in less blood culture contamination rate. What about diversion? Diversion technique, or the practice of discarding or excluding the first part of venipuncture sample, was found effective in reducing blood culture contamination from peripheral sources. The articles used diversion methods through either 1. Diversion device, or 2. Blood collection tube. Of the 15 articles on peripheral sources, 13 of which examined the impact of initial specimen diversion. 9 articles performed initial specimen diversion using a device. Some investigations used TheraPath and some used Curin. 4 articles used blood sample collection tube as a means to divert the initial specimen. Diversion technique using blood collection tubes. How these investigations discuss sterility of the blood collection tubes used for initial sample diversion. Prior to Zimmerman's study commencement, lithium heparin blood draw tubes were sent for gas sterilization in the hospital's central supply. Each sterile tube was individually packaged in single-use sterile packaging. The aim of Lalezari study in 2020 was to test an initial sample diversion technique, or ISDT, under real-time condition. Using externally non-sterile vacuum sample tubes for the diversion. A concern with their method of initial sample diversion technique was that the collection tube preceding the blood culture collection might itself be a source of contamination, potentially originating from the tube stopper, carried into the blood cultures drawn afterwards. In addition, contamination levels of non-sterile tubes may vary from lot to lot. To address this limitation, the sterility of blood collection tube stoppers were tested for several locations where tubes were stored. One tube of 150 tested grew Pseudomonas and another grew Escherichia vulneris. In addition, none of these five needle holders tested were contaminated in their interior. Hence, surface colonization was an unlikely source of contamination. Moreover, the rate of contamination with their method was 1.68%, similar to the previously reported contamination rates of 0.94%, 1.4%, and 2.4% when initial sample diversion technique was applied using sterile and ethanol disinfected collection tubes, respectively. In the investigation made by Said, alcohol wipes were used to cleanse the top of a 7 ml gold or green top tube, rub hard and let dry. The same can be said with the study made by Ben Camis in 2014, wherein top of blood culture collection tubes, sodium citrate is used in that study, wherein it was cleansed with an alcohol swab and used to collect the initial small amount, or blood drawn, through the butterfly needle. Staff collecting blood culture samples. While there were investigations wherein physicians and intravenous therapy teams collected blood culture samples, phlebotomists and nurses were noted to commonly collect blood culture samples from peripheral sources. In the investigations by Ramsey in 2018, there was no difference in blood culture contamination among the samples collected by phlebotomists, nurses, and physicians. Education and feedback. Three studies explicitly indicate the use of education and feedback intervention, and the positive turnout they had in the blood culture contamination reduction. Boyce in 2013 underscores the education content. Said highlights the frequency of education, and Binkamis accentuates the importance of monitoring and feedback in impacting the practice of blood culture sample collection. Here is the outcome synthesis. Blood culture contamination was reduced from 30% to 66% in the investigations which used blood sample collection tubes as diversion, while 34% to 90% in the investigations which used diversion device. Besides reduction in blood culture contamination, Zimmerman and others in 2020 also noted that diversion using blood sample collection tube reduced the likelihood of patients getting admitted as well as their length of stay. Though blood culture contamination decreased in the investigation by Buzzard and others in 2021, the number of repeated blood culture tests, length of stay, vancomycin therapy days, and vancomycin serum concentration had no difference after implementing the use of diversion device. Nielsen and others in 2022, on the other hand, reports vancomycin therapy days shortened with their use of diversion device. Other outcomes. Though blood culture contamination has been associated with avoidable cost, as mentioned by Skogeld in their study in 2019, and initiatives addressing this challenge are expected to reduce avoidable cost, only 5 articles, in my review, included hospital costs as one of their outcomes. Zimmerman in 2020 disclosed that their study using diversion process with blood collection tube also reduced their admission disposition and length of stay. Nielsen in 2022 associated the use of diversion device with reduced vancomycin therapy days, while Buzzard in 2021's use of diversion device did not find any difference in terms of repeated blood culture tests, length of stay, vancomycin therapy days, and vancomycin serum concentration. Discussion. It is worth noting that Articles 1 to 3 offer reasonable recommendations to reduce blood culture contamination from central devices. Levin and others in 2013 suggested to collect blood culture samples from non-wire hub of central devices. Cambodge in 2015 proposed the use of passive disinfection to help reduce contamination from central devices. Boyce in 2013 advised that the active disinfection, the use of disinfecting agents with each use of device in central device management helped reduce blood culture contamination. The use of passive disinfection could offer other benefits as well, as seen in a couple other studies. Gillis and others in 2022 and Tejada and others in 2022 found that the use of antiseptic barrier caps, a form of passive disinfection, prevented central line associated bloodstream infections. Holroyd and others in 2017 found a high incidence of central device catheter hub bacterial contamination, which correlated with positive blood cultures in 2 of 3 total bacteremia cases identified in the 45 patients. In another study by Stahl and others in 2010, it was determined that contamination is higher from central devices than peripheral and arterial sources. This may support Boy's 2013 initiative implementing a policy to prohibit blood culture collection from central devices. In an article published by the Joint Commission in 2022, routes of central device contamination was brought to light. The figure on the right illustrates how central devices can become contaminated through different routes, extraluminally or intraluminally. There's another article which was written by Marshall and others in 2008, enumerating the 5 primary causes of central catheter infections following insertion. The routes include device contamination, infusate contamination, hematogenous infections, skin organism, and the insertion site, as well as the catheter hub contamination. Lastly, the SECO and others in 1989 also identified the source and route of microbial colonization of parenteral nutrition catheters. These articles demonstrate that the mechanism of contamination from central devices is more complex than that of the peripheral sources. It would be noteworthy to look into how to prevent blood culture contamination from this perspective, especially that in an emergency department setting, patient population greatly differs. For example, central device insertion procedures are frequently performed in this space. Emergency departments also receive patients who have central devices which were inserted from previous encounters. The 3 articles which discuss actions to reduce blood culture contamination from central devices provided valuable findings. However, as demonstrated in the syntheses of interventions and outcomes, these are not suffice and that practice change cannot be advised at this time. Generating new knowledge to strengthen current body of evidence is deemed warranted as shown in the evidence-based practice flowchart. As to addressing blood culture contamination from peripheral sources, studies included in this synthesis corroborate that the use of diversion method is effective in reducing blood culture contamination. This concept is parallel to what Anjanapa and others in 2015 endorses, that skin can be disinfected but not sterilized, and up to 20% of skin flora remains viable in the keratin layer of the skin, even after skin prep. As reflected in the included studies, blood sample diversion method can be done in 2 ways, either through blood collection tube or through the diversion device. Thoughtful benefit-cost analysis comparing alternatives is an important tool which can help the decision-making process. Conclusion, implication, and recommendations. This review determines that sufficient evidence is not available to endorse any practice change recommendation to address central device blood culture contamination. And diversion technique was found to be effective in decreasing blood culture contamination from peripheral sources. Although all 3 articles on central devices included in this review offered reasonable recommendations as follows, collect from non-wire hub, employ passive hub disinfection, and initiate 2 nurse protocol, more evidence is needed to support any recommendation. With insufficient evidence to inform any change, generating evidence through research is warranted. In the discussion above, it was confirmed that central device contamination is multifaceted, which can be the focus of future research endeavors in this area. Opportunities which are available to explore include reducing contamination risk in the context of pre-procedure, during, and post-central device insertion. Reducing contamination risk in patients with existing central devices with focus on device handling, that is, ensuring infusate is free from contamination risk, manipulation or access technique, and site care, keeping in mind variation in device duration. The other important area of opportunity that this review revealed is whether or not the use of diversion technique, since it was found effective in peripheral sources, is viable in reducing contamination from blood cultures collected from central devices, and how this technique affects testing accuracy. While knowledge still needs to be generated in this space, there is still an actionable measure institutions are recommended to exercise to ensure that blood culture collection from central devices is truly indicated. Monitoring this practice, which entails educating ordering providers and empowering nurses to advocate for this practice, could help improve contamination rates from central devices by reducing total number of collections. On the side, the syntheses of evidence demonstrate that diversion of initial blood sample is effective in reducing blood culture contamination from peripheral sources. Diversion could be done in two methods: use of blood culture collection tubes or diversion device. In selecting solutions among these alternatives, several factors could be considered. Note that diversion method using collection tube, as used in the included studies, entailed additional measures in preparing the collection tubes. Besides, how the new process fits the unique characteristics of the setting. Another factor to consider is how the proposed change served the purpose in terms of payoff. For example, the synthesis of intervention distinctly used two brands of diversion device. In deciding which brand to use between the two, elements such as product design and operability must be factored in. Ultimately, with the best available evidence as presented in this review, combined with clinical expertise and patient values and preference, a meaningful evidence-based practice change could be reached. Here are the reference for the evidence review, and thank you.